Hello, and welcome to another podcast. Today we're going to talk about the management of meningitis. And meningitis is fortunately not very common, but it still has quite a high mortality rate. It's been known for quite a significant amount of times. It's been recorded in countless textbooks throughout history, but really came into vogue around 1828 when a general surgeon coined the term meningitis, and it's pretty much stuck from there. Now, meningitis can be difficult to detect in the field, but it's very important that if meningitis is suspected, that management and evacuation for it starts immediately. So today we're going to go through what meningitis is, certain risk factors. We'll talk about the clinical features that you'll find to spark your index of suspicion, and then we'll go through the levels of management that is required for meningitis. So we'll get straight into it, and we'll just start with a bit of an overview. Now, the mortality rate can be as high as 25%, depending on what region of the world you're in. In the US, it sits around 14% of cases will end in death, and the last statistics that are available has around 380,000 deaths in 1 year, and close to 9 million cases reported worldwide of meningitis itself. So it seems relatively common, but in reality it is quite rare, but it is important to continue to think about because it is life-threatening, as mentioned, the mortality rates. Now, most of the cases are actually unknown. Okay, so 40% of the cases of meningitis will have an unknown origin, mostly because it's usually fixed by the time they do a lumbar puncture, and in a lot of cases a lumbar puncture isn't done. Now, a lumbar puncture is the only way to actually determine whether or not it is bacterial or viral. Doing blood cultures, things like that, is great for finding bacterial, but it's not really 100% indicative of whether or not it's the cause of meningitis. So lumbar puncture is gold standard, but it's not often done, which means 40% of the cases are actually unknown. Of the known ones, viral is the most common cause, but these symptoms are quite mild. Okay, they're not really debilitating unless you get a couple of quite special viruses, which include your herpesviruses, including Epstein-Barr, herpes simplex, and varicella zoster, but most commonly it's caused by an enterovirus, a non-polio enterovirus to be very specific. Now, these viral infections will often cause, headaches, but they're not necessarily the life-threatening ones, whereas bacterial meningitis is the biggest concern. It's not as common, but it has a much higher mortality rate. 1 in 6 people die, and for those that don't die, they have high cases of sequela. Now, sequela is just a fancy way of saying a condition that is caused by another condition, and 1 in 5 people will get severe complications. Now, obviously, meningitis is linked to meningococcal, and one of the main causes, not the main cause, of bacterial meningitis is Neisseria meningitidis, and obviously that causes your meningococcal. Now, that unfortunately has been on the rise, not significantly, but still on the rise in Australia from 2014. So since 2014, we've had increased cases of meningococcal meningitis. Now, despite virus and bacterial being the ones to look out for and the most common causes of known meningitis, it can also be caused by non-infectious, and they include your autoimmune disease, your cancers, and also drug reactions. When we move into management, you'll find very strong links between meningitis and sepsis. And obviously, an infection causing meningitis can easily cause sepsis, and the protocols will overlap. Okay, let's talk about the risks. Now, obviously, certain areas of the planet are at much greater risk than other areas. There's a band or a belt in Africa that has actually been coined the meningitis belt, and it's sub-Sahara Africa, basically stretching from Ethiopia right through to Senegal. So if you're in that region, it's the highest rate of meningitis. But if you're out of that region, then you still have about a 1.3 in 100,000 population chance of getting meningitis. Now, certain characteristics increase that risk profile. That is, anyone living with a chronic medical condition, which makes sense, more prone to infection, more prone to meningitis. People that are under-vaccinated, so this is unfortunately the case for a lot of children that have parents that don't want to vaccinate their children, they are at greater risk. Living in crowded conditions is why it's still a popular thing for the military, because military barracks has been well publicised through literature of being an increased risk of meningococcal meningitis spreading. Travelling to those endemic areas and obviously vectors, so mosquitoes and ticks can transfer meningitis. People that abuse alcohol a lot, and also there's a strong link with recent illnesses, in particular any rhinosinuvirus, sinusitis, otitis media, and obviously your herpes virus have had close associations with increasing the risk profile of meningitis. As far as age, it's the little ones that are affected. Children under the age of 5 cop it pretty much the worst of all the age groups. But then there's a group, 15 to 25, that are the highest risk of contracting meningococcal, which is why, again, it's a particular interest to the military. Once people get over the age of 50, the causative agent changes to listeria, and that becomes the biggest risk. Now, it's not everybody over the age of 50. It's usually coupled with chronic conditions and immunocompromise as well. Right, so let's spend a bit of time talking about what meningitis is. So if we remember, the meninges themselves are the 3 membranes, so the dura mater, the arachnoid mater, and the pia mater, that line the vertebral column and the skull, so it enclases the brain and the spinal cord. And meningitis is sometimes mixed up with encephalitis, especially since we have the vaccination for Japanese encephalitis. So it's sometimes mixed up. Now, encephalitis is inflammation of the brain itself. Meningitis is inflammation of the actual meninges. And it can be any one of those meningeal areas where it starts, but most commonly it's the arachnoid mater where it gets most of its spreading and does most of its damage. So as you could imagine, the pathophysiology is quite simple. Once you get inflammation of the meninges, you obviously have an increase in pressure, which can lead to an increase in intracranial pressure, but in reality, it also stops the drainage of cerebrospinal fluid. So the carotid plexus is still going to produce cerebrospinal fluid based on your body's perfusion. And when it goes into a space that is inflamed and reduced in size because of swelling, that it's going to cause symptoms by putting pressure on the brain and the associated structures around it, like your spinal nerves. Now, the way meningitis gets into the body has 2 main routes. So we have a hematogenous seeding, which is another way of describing bacterial or viral colonization of the nasopharynx, and that enters the bloodstream via mucosal invasion. Upon making the way into the subarachnoid space, the bacteria or virus crosses the blood-brain barrier and causes direct inflammation and that immune-mediated response. The other way to get it is direct contagious spread. So the organism will actually enter the cerebral spinal fluid via neighboring anatomical structures, and that's where your otitis media, sinusitis, herpes comes into play. And when you're dealing with herpes, it can obviously travel along the neural pathway because it usually sits in the ganglion. Certain medical devices and penetrating trauma can also be a way of contracting meningitis. So let's break down what sort of things you're going to see when you're dealing with meningitis. So it's a spectrum, and therefore can have a varied clinical presentation depending on age and immune status of the actual host. Now, typical speaking, when you're dealing with bacterial meningitis, 95% of cases will have 2 of the 4 main symptoms highlighted on the screen. So fever, altered mental status, confusion, delirium, headaches, and a stiff neck, 2 or more of those are present in 95% of bacterial meningitis. They're also present in viral meningitis and non-invasive meningitis and fungal meningitis, but bacterial meningitis is the most lethal. Therefore, we treat bacterial meningitis based on suspicion. So when you're looking at a clinical presentation, the easiest way, looking at the description in front of you, is to break down the actual findings that you have. So the main thing that you will find when you're dealing with meningitis is your meningeal irritation. And that irritation can give you a bunch of symptoms that the patient can describe. So if you have irritation around the brain, it usually comes with a headache. If the irritation extends down the spinal cord around the neck, they'll explain a stiff neck and pain on extreme movement of the neck left or right. And that is obviously linked with that jolt attenuation sign, which you use to try to detect any meningiisms associated with your headaches. And this can also lead all the way down the spinal cord with someone complaining of a sore back. Now, if the meningeal irritation gets bad enough, then you can have associated cranial nerve involvement, which brings in your cranial nerve paralysis and also photophobia. Now, cranial nerve involvement is only present in 10 to 20% of cases, so it's not a guarantee. So from what the patient can tell you about, we can also do physical signs and investigations to try to get more positive signs towards meningitis. And that's where our Koenig's and Brzezinski's sign comes into play. Now, the descriptions written on the screen can be quite difficult to get your head around, so I'll do my best to describe it. These tests are done when the patient is lying supine, so flat on their back. The best test to do first is the Koenig's sign. Okay, that involves lifting the knee up to 90 degrees, so full hip flexion, and then grabbing the leg and extending it up like you're stretching the hamstring. A positive Koenig size will increase the pain when that hamstring is stretched because that puts pressure on the nerve and therefore puts pressure on the spinal cord, which is inflamed. Okay, from there you can lower that leg down so they're resting with their knees bent up, almost like you're compressing the lower part of the spine. So they're sitting there with their knees up, sort of like what you would if someone had an abdominal injury. From there, you get them, or you lift their head up. What you're doing in that particular movement is you're increasing the pressure that will be felt around the lumbar and thoracic spinal cord, and if it's inflamed, will obviously increase the pain. So they're the signs that you can find. Now, obviously, as meningitis gets worse, it can spread to a systemic inflammatory response. And when you get a systemic inflammatory response, you have involvement with the blood, and therefore you can get a fever. And if the inflammation near the brain is bad enough to put pressure on the brain and increase intracranial pressure, then you'll get your altered mental status. If a person has altered mental status as a result of meningitis, their prognosis is the worst. And it is a medical emergency. Okay, so they're the ones that are mostly associated with high mortality rates. You can get the other symptoms of meningeal irritation in normal viral meningitis, and it's not too bad. You still treat it as we'll go through, but once you start getting that altered mental status, then it becomes an increase in mortality rate. The other end, when we hear about these rashes that can happen, they're mostly associated with meningococcal. So meningococcal itself will cause a vasculitis, and that will cause a discoloration of the skin, so you'll get a purpuric rash, in particular the legs themselves. Now, this is the case for about 50% of meningococcal infestations, okay, so not all of them, and can also be a sign of viral and other bacterial meningitis. So it's definitely not a diagnostic tool for meningococcal, but it certainly increases the probability. So bottom line is once we have a note of probable diagnosis, then we move into our treatment. So that can be a fever, neck stiffness, headache, altered metastasis. 2 of those, 95% of cases, or 4 of them, huge increase suspicion of bacterial meningitis. Now the treatment for it is pretty much starts on the suspicion of bacterial meningitis. So the best thing you can do, because the drugs are given on order, is if you suspect it, you make a phone call and you arrange for evacuation if you're in a position that is not best suited for meningitis. So the starting of this management is once you suspect it on clinical presentation, you make the phone call and you get the ball rolling for evacuation. From that point of suspicion, and if the medical officer agrees based on your handover, then you start treatment. And whilst you're doing the treatment, you can delve deeper into a better history, where you talk about where they've gone, certain illnesses, increase certain risk factors, those sort of things. And we'll talk about a few more as we go through, but you do it concurrently. You start treatment. Once the go-ahead has been made for bacterial meningitis or meningitis itself, you start treatment, and medication is the goal within 30 minutes after you suspect meningitis. So you want to give the primary medications within 30 minutes of suspecting meningitis, which may sound easy until you're actually in a case where you're doing it. Time can easily slip away from you. Certain complications of meningitis can be fitting, and it can also be misdiagnosed with hypoglycemia or actually manifest hypoglycemia. So if you notice any of these, then obviously fix them accordingly. You fix hypoglycemia on direct evidence of hypoglycemia, not suspicion. And if they're fitting, you obviously give your benzodiazepines to control that. Because we're dealing with meningitis, it's quite easy to forget that the patient could be in pain or could be feeling nauseated as a result of meningitis. So try not to forget that, and part of the treatment regime can be to give analgesia and antiemetics as they're required. So just keep those in the back of your mind, because we won't discuss them specifically in the protocol, but they can be complementary management that will need to be taken care of. So starting at the start, when you're in intake, you're by yourself, we've got to get a good set of vital signs. Now we obviously need to look out for a fever that denotes a worse infection. Glasgow Coma Score, again, increased probability of mortality and evacuation priority. Blood glucose, as we discussed, and we need to know the perfusion status, and they're the most important to monitor. Because meningitis can lead to a systemic infection and systemic inflammatory response, you can get associated distributive shock as a result of meningitis. Remember, I mentioned it's closely linked to septicemia, so therefore you can get the associated problems of sepsis. Now, O2 is rarely required, but if it is, you give as minimal as possible to keep it at that 94 and above % on your SpO2. Intravenous cannulation is essential. You must obtain 2 IV lines, and if you can't get IV lines, you're to immediately go to IO in order to give the fluids and the medication as required. Most of the medications can be given IM, but they are very much subpar if you don't get IV or IO access. Okay, so there should be no reason why you can't get either one of those access. So always aim for 2. Fluid therapy for 1. You have to give 20 mils per kilo as a stat dose in order to maintain their perfusion, just like you would any other shock. And the other one is to give the medications and infusions. Now, dexamethasone is the corticosteroid that is given for meningitis, and you give 10 milligrams IV stat is best. Okay, so IV is best for this one. Now, this is given before or with your first dose of antibiotic. Now, if given early for bacterial meningitis, it has been proven to improve outcomes of morbidity and mortality. Okay, so that's great news. Now, there was a risk profile out there associated with increased GI bleed risks, but pretty comprehensive studies has shown that it doesn't actually increase the risk of GI bleeds, but it absolutely does improve outcomes, so it is to be given at the earliest opportunity. Depending where you are, the extended management can be done in a treatment team or by yourself if you're an integ. Some of the medications are quite difficult to carry if you're an integ, especially if you don't have a vehicle. So that's why a treatment team can be an option, or storing these things in a vehicle can also be a pretty good point of call to do this whilst you're traveling to a high facility, so whilst en route care. So the main antibiotic of choice is ceftriaxone. Now, there obviously is another one that can be provided, which is cefotaxime, 2 grams as well, but we don't often carry that one. So ceftriaxone 2 grams is often the one that will be carried because it's linked to other conditions that also require ceftriaxone. So it's a lot easier just to carry one as opposed to carry the two when they're pretty much been proven to be interchangeable with very similar bioequivalents. So we mix up the ceftriaxone, which is 2 grams in 40 ml, and we give that IV and we push it over at least 5 minutes. Hence why we want the other line running if any fluid therapy is required. Okay, from there, you look at the profile of the person, and if they have an increased risk of listeria, meaning they're over 50, immunocompromised, live with cats, those sort of things, then we add benzopenicillin 2.4 grams in 20 mils, and that's a 30-minute infusion. Okay, so quite a slow one. That's only if there's an increased risk of listeria. Now, if meningitis is linked to sepsis, then we also give our gentamicin the same way we would if it is sepsis alone. Okay, so quite a difficult medication to give on the ground. So it's recommended, if you don't remember, to go back to the sepsis lesson and have a look at how to administer that gentamicin. As you're administering the antibiotics, we think about the probability of herpes simplex encephalitis being involved. The easiest way to do that is to ascertain whether or not the person's had a recent herpes simplex cold sores infection in the last week. If they've had an active one of those in the last week, then encephalitis can be suspected, and we give a alcyclovir 10 milligrams per kilo infusion. Now, this can be quite a difficult medication to administer. So I'll do my best to describe it, but it's always recommended that you practice it and check any handy medication training tools that you may have, especially if you have access to the ADEL site, to go through how to administer this. So acyclovir itself comes in 250 milligram or 500 milligram vial in 10 or 20 ml themselves, hence why it's difficult to carry as an integ. Now, because we generally work with adults, if we're only working with adults, try to carry just the 500 milligram one because it's less vials to go through for the doses. The dose is 10 milligrams per mil. So if you have a 70 kilogram patient, that means you need to administer 700 milligrams. Best way to do that is to obviously give an entire vial, which leaves 200 milligrams over that you take from the second vial. When you're looking at starting an infusion, especially an infusion that says that the mix is to be at least 5 milligrams per mil, the first place to start will be to find out what your total infusion dose will need to be at a minimum. So because the dose required for the patient we're talking about is 700 milligrams, you simply divide that by 5, which will give you 140 mils. Now, because it's close to that 100 ml mark, it's best just to use the 100 ml bag of normal saline and add the additional fluid to it. So if you put the first vial, the full 20 mils, 500 milligrams, into the bag, 100 ml bag of normal saline, you obviously get your 120 mils infusion. From there, we need an additional 200 milligrams for this dose. So the vial, 500 milligrams and 20 mils, means that it's 25 milligrams per mil. So you simply draw up the additional 8 mils you need, inject it into the IV bag, and then add an additional normal saline to make up your infusion rate. Now, because it says at least 5 milligrams per mil, it's easy enough just to add another 20 mils on top of that, so then you know that you are over that 5 milligram per mil, and therefore it's a safe infusion to administer. From there, you run it over 1 hour. Okay, so you start the infusion. It's obviously best to be done through an infuser, but if required, you can calculate the drip rate. Okay, so most people in the military will require 2 vials. Okay, some obviously requiring the third. And because they're 20 mil vials and you need infusers and things like that, it's often best to have in a vehicle or a treatment team, which is why it sits in the realm outside of that initial intake response. Now, whilst you're in the treatment team, obviously you can do some ISTAT investigations, but in reality, they're best done with the rest of the pathology profile, which will be generally done in our Roll 2E or higher. So once they finally get to the definitive care, then they will continue the fluid, they'll continue the antibiotics. This will obviously continue en route to definitive care, and obviously whilst in definitive care. When we get the ability to do pathology, then pathology can be taken for meningococcal PCR. We want their blood gas, full blood count, liver function test, UNEs, glucose again, and any coag studies. It's standard practice to get blood cultures, so we want to take 2 anaerobes and 2 aerobes from 2 different sites once we can. But in reality, the lumbar puncture is the gold standard. So if we have the ability to do a lumbar puncture and actually test cerebral spinal fluid for the pathogen, then that is obviously best case. If we don't, then we stick with our blood cultures and we continue our bacterial meningitis management based on our index of suspicion alone. Okay, so that's the management overview of meningitis. Now there's a few other things, education and holistic things that need to take into account when we're dealing with meningitis. So meningitis can equal a stay in the ICU for a couple of days, and then you can even be in the ward for a week or so thereafter. So it's quite debilitating even after the initial management is done, and obviously can be associated with long-term complications as well. Now, if meningococcal itself is confirmed, then that is a notifiable disease, and the public health unit needs to be informed within 6 hours. So this is within 6 hours of meningococcal being confirmed, not in the field meningococcal suspected. So we start treatment for bacterial meningitis. It needs to be confirmed. The only way to really confirm it, lumbar puncture, you can get away with blood cultures and a meningococcal PCR. So once it's confirmed, it needs to be informed. So obviously that's not the job of the INTEG on the ground, but just know that it is a notifiable disease. Vaccinations are available. Vaccinations for meningococcal C has been available since 2003. In 2018 is when ACWY vaccination that we get now was introduced to include infants. It was available before then, but from that point on, it includes infants. So as clinicians, it is best for us to inform people with children to get their children vaccinated with ACWY vaccination for meningococcal. Okay, that is the best coverage against meningococcal meningitis. Now, as mentioned at the start, we have had an increase in Australia of meningococcal since 2014. So there's been a steady increase since 2014 of meningococcal. Before that, the rates dropped dramatically. We're talking a massive drop to the point that it was a very controlled disorder within Australia. But then in 2014, we started to get an increase, and the increase has continued up until 2022 when the stats stopped for now. Okay, so as mentioned, I know there's a lot of anti-vax campaign, a lot of confusion out there about vaccinations and whether or not pharmaceutical companies are corrupt. Now, obviously, corruption exists in all areas of pretty much everywhere, but the evidence is sound that vaccinations work, and vaccinations reduce the probability of getting the disease, which is not only better for the individual, but also better for the community itself. So vaccinate your children, vaccinate yourself, and do your part for the holistic care of the community. Okay, that brings us to the end of meningitis. As mentioned, very closely linked to sepsis, so often a good protocol to look at together and practice together. It is quite difficult to give the medications on the ground and in a vehicle, so it's best to practice those actual protocols. Have guides available to you so then you can have the answers at your fingertips of how to administer these medications, and just start discussing prevalent rates, meningitis linked to sepsis, and get better familiarization on the management of the two conditions. But until next time, take care.